My disclosures, solely responsible of this presentation, although the case was presented at the local IRB where I was working at that time. My outline, I will briefly review the problems of prematurity, the use of tocolytic drugs to prevent premature labor, the research project, and then I will discuss with you the ethical issues related to clinical trials in preterm labor. A preterm birth is defined as birth occurring between 20th and 36 weeks of gestational age. And preterm complications are the leading cause of death among children under the age of 5. And also preterm birth causes severe neonatal morbidity, and premature newborns that survive may require lifelong care. Premature labor treatment is usually done with tocolytic drugs that allows pregnancy to be prolonged for at least 48 hours. That provides a window of administration of antenatal corticoids or in utero fetal transfer to an appropriate neonatal health care setting. At the time of submission of the research protocol, the most frequent drug used in Chile were beta-mimetics that were effective in delaying birth at least for 48 hours, but that produce particularly maternal side effects, causing treatment discontinuations. So a new tocolytic agent was presented. It was atosiban, that is now in use. And atosiban is an oxytocin antagonist that inhibits preterm uterine contractions without apparent, at that moment, significant cardiovascular, pulmonary, or central nervous system side effects. At that time, data suggested that its use to delay labor could be as efficient as the current use of beta-mimetics, but with fewer side effects. So the aims of that research protocol was to compare the effectiveness and safety of the oxytocin receptor antagonist atosiban compared with beta-mimetic salbutamol in the treatment of preterm labor. Inclusion criteria were maternal age between 16 and 44 years, a singleton pregnancy, intact membranes, and gestational age between 24 and 34 weeks, reported or documented uterine activity, cervical dilatation between 2 and 4 centimeters in an otherwise normal pregnancy. The outcomes, the primary outcome was preterm birth, less than 37 weeks, and secondary outcomes were preterm birth between 48 hours of administration of the drug and at least 2 doses of corticosteroids administered prior to delivery, and also preterm birth within 7 days of randomization. Both groups received standard obstetric care and neonatal care provided by the neonatal intensive care unit if it was needed, and there were no other interventions associated with the participation of the trial except for strict data registration and non-invasive neonatal follow-up. We addressed several ethical issues regarding this trial. The first one was if there was an ethical justification of doing the trial. And we considered that inclusion of pregnant women in this type of research was justified because the outcome of the trial is relevant to the health needs of pregnant women and their fetuses. The study cannot be done in non-pregnant women, and the trial was supported by reliable evidence in animal studies and phase 1 studies in non-pregnant women. Was an ethical justification of doing this trial in our local settings? We considered that yes, it was justified because pregnant women in our setting also had premature labor. The standard therapy at that time with beta-mimetics poses important health risks for the pregnant women. We did have a well-implemented neonatal intensive care unit, and the new drug was considered that will likely to be available after the term of the trial for local people. When to consent was, When to consent was a problem, considering that pregnant women with premature labor were in pain, in fear, and distress. So local IRB suggested at that time a pre-consent procedure and full information regarding the trial during normal obstetric checkups, so that every woman that attended our hospital was well informed about this trial. And from our point of view, this allowed enough time for women to consider enrollment and understand the maternal risk and potential benefits for the newborn of using the standard treatment or this new drug. We also addressed the issue if there was a need or not of the father's consent. According to the Code of Federal Regulation, if the research holds out the prospect of direct benefit solely to the fetus, which will be this case, then the consent of the pregnant woman and the father should be obtained. However, according to our Chilean law and from my own personal views, only the pregnant woman should give or deny the consent, although consent from the father is always desirable. We also address the issue of the balance between the interests of the mother and the infant, because the main health risk of prematurity is for the newborn. And on the other hand, the tocolytic treatment poses mainly health risks for the mother. So the IRB should establish risk-benefit ratio for both mother and the child during this type of trials. Also, we considered that it was important to determine actions if the initial treatment fails. Should they move to the standard care? The standard drug at that time was beta-mimetics. And also we considered that for this type of trials, it was very important to have an external monitoring committee, at least with 6 months report. And also we discussed which were the obligations of the sponsor. We did consider that the study design should choose a site that at that moment has the best standard of care. Those complications inherent to the condition of prematurity, for example, the hospitalization of the newborn baby and so on, should be paid by the Social Security, but not by the research project, although the sponsor should pay for the newborn follow-up, and also the sponsor is required to have insurance to cover for any adverse events. In conclusion, we do think that inclusion of pregnant women as research subjects for acute medical conditions, such as, for example, premature labor, raises important ethical questions, and that local IRB should consider not only the way that the informed consent process is conducted, including the time of consent, but also how this research can be implemented safely within local facilities. And thanks, and special thanks to Joseph Millen, who kindly reviewed this case.
Thank you very much. I'm Imelda Namagembe from Uganda. It's good to note that the IRB thought of that idea of the prenatal consent. Of course, I do appreciate the challenge that a number of our women, not 100% attend antenatal, but globally, when you look at the figures of antenatal, at least more than 90% of the women can go to antenatal. Probably that would be the best time to inform these women, to get to know about these studies, and then later on, when they come in that situation, when they've already given us information, because a lot happens. And then the other challenge at times we notice in some environments is that with environments of scarcity in some places and shortage of manpower, and the way what happens, there are some literature at times which shows challenges in issues of dignified care in our environment. So probably that idea of trying to inform these mothers about these studies in the prenatal is really a very critical step if we can follow it. And then later on, we follow it up further to get a reconsent process when they are in labor. I think that's very good. It can be taken up and followed up further. It can, because at least more than 90% of the women tend to get prenatal care in most of the cases. So I think as researchers, we need to utilize that time. Of course, there are some who come in later on when they've not had a chance of attending antenatal. The rest we'll discuss later on. Thank you.
Thank you, Sofia, for the wonderful presentation. So I think you raised a very important question in your presentation, and that is the involvement of the partner or the husband or even the family in the consent process. And this becomes a very critical aspect of consent taking in those countries like mine, where women may not have insurance, may not have any kind of third-party payer who will pay for their bills, and it's usually the family or the husband who bear the financial cost of the disease and the outcomes. And so I think this is a larger question. So this is a question and a comment, really. So thank you very much for raising that.
I will make a short comment about that, because if you have a financial interest from the family or the partner, because they are paying the bills, maybe they will push a woman, for example, to participate on a trial because of the financial incentives. And that, I would think, it's something that an IRB should look carefully, if that is an inducement to participate. But I am fully aware that we have several differential cultural settings. In my country, the father will not be considered necessary to give the consent for the woman, even if he pays.
Hi. Carly Krubner from Johns Hopkins. I had a question. Thank you so much for your case, Sofia. About the outcomes of interest and, again, who the prospect of direct benefit was in the case of this research study. So given that the standard of care had adverse maternal outcomes and that the study was to compare whether or not the new treatment had fewer maternal adverse outcomes, I was just curious, when you talked about those primary and secondary outcomes, it didn't mention the maternal outcomes. And also you mentioned that the prospect of direct benefit in this case was to the fetus, but if the standard, either way they were going to get something to delay preterm delivery, it seems to me that it might actually be the prospect of direct benefit of enrolling would go to the mother, because it would reduce her chances of those adverse outcomes. So I was wondering if you could talk a little bit about that.
Well, mainly maternal side effects will make the drug to be discontinued, stop the trial, and move on to the regular treatment at that time. So that was also some of the outcomes that were needed to be recorded. If there was any adverse event for the mother, mainly tachycardia, if she was on the standard care, that was also recorded. But in terms of space, the main, I had to reduce some of the slides, and the main outcome could be if the drug was able or not to delay delivery for at least 48 hours. That was the main primary outcome. But we did consider, obviously, all those maternal side effects.